Good afternoon, everyone. I'm Cynthia Hunderfeen, a senior partner with the CEO Advisory Network. I'll be your host for this webinar. First, let me tell you just a little bit about me. I formerly served as the Chief Administrative Officer for the Cleveland Clinic, which is a nationally recognized medical center with over 72,000 employees, 21 hospitals, and 5,000 physicians. And most recently, I was the president and CEO of the Allegheny Health Network, a Pittsburgh, PA-based health system with 23,000 employees and 14 hospitals. The CAO Advisory Network is a team of highly accomplished healthcare leaders that have senior level executive experience with a passion to leave a legacy by assisting forward-looking CEOs and senior executives in their organizations. And today we're really pleased to sponsor this webinar on how not to succeed in a CMS bundled payment program, which will be presented by Avant-garde Health, one of our affiliates. The webinar will discuss the CMS bundled payment program that starts on January 1st of next year, and it will give you information that will allow you to avoid common pitfalls and prepare your hospital to win in the next 120 days. I'm going to turn it over to Derek Haas, the CEO and founder of Avant-garde Health, and Dr. Porter Jones, the Chief Medical Officer. Sit back and enjoy the webinar. Derek and Porter are great presenters, and I know you're going to find the next hour of time very well spent. So Derek, take it away.
Thanks, Cindy, for that very kind introduction. Excited to be talking to everybody this afternoon. We're very interested in hearing everybody's thoughts, questions as we go along. So please don't be shy with raising your hand if there's something you're curious about, or typing a question to the chat boxes as well. We have quick introductions building off of what Cindy, very kind words there. So started Avant-garde Health in 2014, and I'll share a little bit more about the background of the company in a moment. But based in Boston, and joined by my colleague, Dr. Porter Jones, who's our Chief Medical Officer, who's based in Denver. So Avant-garde Health grew out of work I was doing with two of the faculty members at Harvard Business School, Michael Porter and Bob Kaplan. Started working with them in early 2013, about 12 and a half years ago, co-leading their healthcare research. And saw very quickly there's a lot of interest and excitement for people in the concepts. But it's clear people need software to help them take these ideas to be successful, implement in practice in their institution. The other inspiration behind the business is my mother, my father, my brother, my sister, all doctors. So only non-physician in my family. I grew up hearing about all the challenges and frustrations that they were experiencing, trying to deliver high quality care in an increasingly resource-constrained environment. And we're a mission-driven company. Our first and foremost goal is to be helping health systems, physicians, understand all the different facets of the care with the ultimate aim of helping them understand where the opportunities to deliver the care at the same or higher quality, but in a more financially optimal fashion. And just a little bit of background on Avant-garde Health, a little bit more before we get into the CMS TEAM program. We have two primary solutions. The first is around helping to optimize the care while the patient's in the hospital, which is valuable independent of what payment model you're operating under. And the second one we'll spend more time on today as it relates to like succeeding in like a bundled payment model where you're trying to optimize the care post-discharges as well. So starting first within the hospital, and certainly what happens within the hospital is very consequential for being able to be successful managing that care post-discharge as well. Our goal is to help organizations get as robust a set of insight as possible into their true underlying costs for delivering care. So like looking at the specific care processes, as well as like the supplies that are being used for that care. And as it relates to like the supplies, you're looking at both like what utilization variation across different physicians doing the same kinds of procedures, as well as looking at opportunities to renegotiate or lower the pricing for those supplies. And then on the care process side of things, we're using an approach that Bob Kaplan pioneered called time-driven activity-based costing, or TDABC for short. Ideas to understand for each patient, like what care is delivered, who's involved in delivering that care, how much time are they spending. If you know that line with their cost rates, you can say if somebody's spending 20 minutes with the patient, cost of that person's time is $90 an hour, there's like $30 in personnel costs associated with that patient interaction. And so the two benefits of this are like, one, it just really makes it really intuitive, the frontline staff and clinicians, to understand if they make a change in their care delivery, here's what the financial impact of that is going to be. And secondly, Every different hospital has its own unique approach to doing cost accounting today, and so absent a standardized methodology, it's really hard to compare across organizations on an apples-to-apples basis. Secondly, from a improvement perspective, we're helping to highlight opportunities relates to growing case throughput. So like from an OR perspective, like looking at how long different phases of the case are taking, wheels in incision, incision closure, closure wheels out, looking at turnover times, OR and block utilization, applying the same types of principles to be freeing up bed capacity and shortening patient length of stay. Then thirdly, uh, the idea is to be helping ensure the cases are accurately being coded as well. So 97, 98% of the time that they are, we're basically acting as a spell check for the revenue cycle teams to help ensure they're accurately coding their cases. And occasionally we'll catch some mistakes based off of comparing different kinds of data that are being generated for each of the cases. And then lastly, our goal is to be incorporating as much quality and outcomes data as possible to help people understand the whole value of their care. So like not just readmissions, complications type stuff, but patient-reported outcomes, enhanced recovery after surgery, care protocol compliance as well. And we pair that with expertise from our customer success team to help people understand there is an opportunity to share best practices, help people put together a game plan to be successful driving improvements. So all this relates to like looking at the care within the hospital, which is like a important stepping stone to being successful at managing the care post-discharge, which is really important in the bundle payment program. I'd say like a common misconception people have when they are in bundles though is like, oh, all of a sudden it's important for us to be managing like implant spend or supply spend. And the answer is, it's really important to be managing if you're in a bundle payment program, for instance. Okay, so on the bundle side of things, we've been supporting organizations and bundles for the last 9 years, initially with the introduction of the mandatory knee and hip bundle payment program, the CGR program that started in 2016, and then more recently, the voluntary BP side advance program that started in 2018. To my knowledge, we're the only company that's published our work around bundle payments in Harvard Business Review, which we've done twice now. The data you see on the left-hand side of the screen is from our article that we co-authored one of our clients in the BPCI Advanced program around how we're able to help them be successful. They're able to meaningfully lower their costs below the target prices set by CMS, while substantially improving the quality and outcomes of their care as well. And they were participating, across a range of both medical and surgical episodes in that BPCI Advanced program. And then we also wrote an article in JAMA evaluating the impact of the CGR program, the first few years of the CGR program as well.
Great. Thank you, Derek. As you can see, Derek's an old soul when it comes to bundle payments. We're going to put him on the hot seat in about 15 minutes and get his perspective. He's a well-published author when it comes to bundle payments, how to engage physicians, how to look at being successful in these programs. So really excited to have his shy decade worth of experience today. But before we do that, we do want to get into the nuts and bolts of the CMS TEAM program that is set forth to be an active and hopefully a very successful program throughout the country on January 1st of this coming year. So as we look at this, there have been some predecessors in bundled payments that have led up to CMS TEAM. One of which Derek mentioned and has been part of quite extensively, that BPCI program. But wanted to set the stage of what is CMS TEAM. We'll go through this relatively quickly and then get through some more details as well. But it is a full bundled payment program where there is one payment for all services for that patient. So that starts at the time of admission, day of surgery, and goes 30 days out to the date of discharge. So all costs and all care from that admission day and then 30 days out are incurred and in a roundabout way overseen by the anchor hospital, which is where the patient is seen and has the procedure. We do have triggering events, which are based on DRG and HCPCS codes. But ultimately, one thing that is different about this particular program compared to BPCI is it has been augmented into the number of initial or bundled payment or bundled episodes that we're looking at. So now we have lower extremity joint replacement, which we have had some success and experience in previous bundle payment programs, surgical hip and femur fractures, spinal fusions, and then we're adding on some other items like CABG and major bowel procedures. So I think it's exciting to get away from some of the items or the bundles that we've really been used to optimizing on and expanding into different surgical specialties. And the hope is that that will continue to expand as we find that this provides benefit to both the hospital, the providers, and the patients as well. When we look at the overall spend and how these costs are being calculated, you're going to see on the right-hand side, we look at everything that's Medicare Part A and B. So that includes the hospital inpatient costs, but as Derek mentioned, that's more of a fixed cost. Not a lot that can be done there. But then we have other variable costs that we'll talk a decent amount about, like skilled nursing facilities, home health agencies, outpatient services that can include also labs and additional imaging. And then obviously the big or the high runners like hospital readmissions will all go into play. So again, that 30 days, everything is going to be calculated and part of that cost structure for that individual payment, which will lead into what a reconciliation looks like, either going from the facility, from the hospital, or to the government. So let's look at a very high level unmanaged patient journey. And this is the goal when we compare the unmanaged to the managed. As you can see, the hospital or the anchor stay is $13,000. That's going to be a fixed price in the unmanaged or a fixed cost in the unmanaged and managed. Medicare Part B as well to a certain extent. But then here's where things start to change. So for this particular patient, day 1 through 12 going to a skilled nursing facility, discharge from that facility to a home health service, and then finalizing that with outpatient physical therapy. So we got 3 modes of treatment during those 30 days. And if we look at it, target price is $25,000, but overall spend or cost for this patient was $29,900. So when we're now looking at what does reconciliation mean, or what is that going to look like when reconciliation occurs for that particular patient, there's going to be a repayment back of $4,900. Now let's look at what a managed patient journey looks like. Again, we have our hospital and anchor stay, we have our Medicare Part B, but instead of going to the SNF, we're going to skip the SNF and we're going to go for the first 14 days to home health, which is a fixed fee of $2,500. And then for the remaining time, we're going to do outpatient physical therapy. So we pulled back a lot of that cost based on the SNF discharge for that particular patient. Now, if you look at it, target price still is $25,000. This is the exact same patient, but now the overall cost of care was $20,450. So there would be a reconciliation in the positive amount back to the hospital in the form of about $4,500. So as we're thinking about this, really the big difference was that SNF, but a lot of that care and a lot of that preparation comes well before the patient even arrives for their procedure. It is that pre-op optimization, that patient education, setting expectations of what is going to happen the day of surgery, where they most likely will be going home to, whether that is a discharge to a SNF or home health, etc., and really managing that patient as they come through the hospital as part of this particular CMS TEAM program. So now when we talk about target price, and we'll get into some of the mechanics of the reconciliation, it can be relatively complicated. We'll try to simplify it down because this obviously is a very important part of the program. When we look at target price, so let's even just go back here. We see a target price of $25,000. You will have, as patients are part of these bundles, different target prices based on their particular profile. So as we look at this target price and the items that will affect that target price, you have hospital factors. So are you a safety hospital or not? What size? Where is your location and geography? We have other social risk factors like a community deprivation index, dual eligibility between Medicare and Medicaid. But then where it's more easily understood and you have the variability is now the patient. So we look at age, we look at different different pre-existing conditions? Are they diabetic? Are there heart conditions? Do they have dementia or any other disability? So understanding the risk profile of the patient will then alter and change how that target price is looked at by CMS. So this needs to be accurately documented. So as the patient comes and is treated by your facility, you are also working on a fair playing field or on your risk-adjusted target price for that patient that is appropriate for that patient. So there is some work that needs to come in when understanding how you compare to other facilities and making sure that you're accurately collecting and documenting the information that is important for risk adjustment within the patient population. Now, looking at performance tracks, I won't spend a lot of time on this. I'm sure a lot of people have seen this particular view. But remember, the good news for everybody, track one, upside only 10%. We're being allowed as a country and as individual hospitals to test and try this program, knowing that there is only an upside opportunity. There will not be a downside risk for year one. But we encourage everyone to prepare like there is a downside risk in year one because, and Derek can talk to this as well, there's a big learning curve. It's not a 12-month learning curve, it's much longer. So we are encouraging individuals to begin that preparation phase, putting things in order from an org structure perspective, from a analytics and data perspective to understand where you are, where you need to be going, et cetera, over these next few months in preparation for Gen 1. Now, as we look at track one, it can continue. If you're a safety net hospital, years 1 and 3, you can continue as a 10% upside only. And where it differs is track two, as year 2 begins. If you are a safety net hospital or one of these others, rural hospital, Medicare dependent hospital, you can opt in to be part of track 2, where now there's only a 5% upside downside risk. So that risk is mitigated for that group of hospitals. If you're everybody else, once you get past year 1, then there's a 20% upside, 20% downside. And then that changes a little bit of your scenario, moving in from that upside only risk to a potential of a 20% downside if you aren't successful in operating efficiently within this program. And I'll get to the CQS adjustments or the quality adjustments. Some of the quality measures to look at and to think about. All episodes, we're going to look at readmissions. We're also going to look at any sort of safety and adverse events. Within lower joint replacement, they are going to take into account patient-reported outcomes, which is great. We've got some tried and true patient-reported outcomes that we can lean on. And then as year 2 comes, we start to add in some of those quality and outcome measures. So looking at harms with fall, looking at standardization of death rates, post-op respiratory failure, some other items they'll start weaving in. And then we will be doing more patient-reported outcomes as we get into year 3. My feel and guess is this will be a bit of a moving target, slightly organic, and we may be changing how or what things are going to be tracked and part of these year 2 through 5. But exciting that we do have quality and outcomes as part of this. So then how does quality measures impact the reconciliation? Again, in track 1, you can have a positive effect on your reconciliation of up to 10%. And then as we move on in track 2 and track 3, we can have a positive and a net negative reconciliation effect based on quality and outcomes of up to 10% and on a downside of 15%. So very important to be thinking about this aspect of quality and outcomes. It will affect your reconciliation. And we've just found a lot of it also is just that inertia to begin tracking appropriately, thinking about how you are going to be intervening with these patients. And the hope is that it just rolls out to the entire patient population that you're seeing as well at your facilities. Reconciliation, timeline, and process, and we're going to get into this a little bit more and how this data all flows. Reconciliation occurs 6 months after the end of that particular performance period. So as we come to an end of performance period year 1, which would be 2026, we would expect reconciliation to occur approximately in June of 2027. So that will be a lump sum one-time payment that would occur in June of 2027. And again, if you are ahead of your target price or you are spending less than what that target price is, from an overall perspective, as you take each individual patient that you are seeing into an account and roll that up, then you would expect an additional reconciliation or payment to come your way. And if you are over that target, then you will be cutting that payment or cutting that check outward facing from the hospital. And again, on that far right-hand side, there are other factors that come into play, but they adjust your target price. So when you're thinking about the risk adjustment and the quality scores, those will make adjustments to the target price, which then obviously will change your scenario in regards to the overall cost basis of that particular patient or bundle that you're working on at your facility. We're going to use this slide as a placeholder because I wanted to get into a bit of a discussion and conversation with Derek and lean on his experience. There's a lot of nuances with this program. From my perspective, it can actually be a very difficult program, but it doesn't need to be. And so we want to be able to provide some basic tools that allow you to feel like you can be successful, even in a scenario or in an environment where it feels like there is a lot going on. So we'll try to break that down now. And Derek, one thing that I think is interesting, again, going back to this idea, is the flow of data. Even the reconciliation is presumably 18 months after you may see your first patient in January. But then that also prohibits really understanding how you're performing and doing. So if you can touch on how that data comes through to the hospitals, in understanding once they're discharged, how quickly are you seeing data come back, and really understanding how you did or how the patient did within the program. And then, based on that lag, what are you seeing or what needs to be done so that you don't succumb to just this really long lag of not being able to actually make adjustments in real time.
Yeah, excited to talk through that, and just wanted to make sure people saw Kristen's message in the chat. Please feel free to add your questions. We're excited to talk through anything that's top of mind for you all as well, whether it's related to the TEAM program or just more generally helping to optimize and improve care, broadly speaking, under any payment model as well. Please let us know it's top of mind for you. So to Porter's question, if you have like a patient has a procedure in January, CMS won't start to share any claims data related to that case until March or April timing. And then it will take until, like, roughly speaking, like August timing for 99% of the claims to come in for that 30-day episode. And so that's really quite a long time to wait to understand how you're performing in the program, and to then be able to hopefully course correct in a timely fashion or know where to focus from an improvement perspective to be able to care as best as possible for all the patients in the intervening time frame. And so in terms of like having closer to real-time view of how things are tracking, it's possible to use EHR data to have an initial view of like what is both expected episode spending for that patient going to be, or predicted episode spending for that patient going to be, based off of those patient characteristics, the kind of procedure they had, where they were discharged to, as well as like how the target prices from CMS may adjust and shift as well, based off of your actual patient case mix in the program, to the extent to which those patients are healthier or sicker than they were in the baseline period. CMS is going to be making those dynamic target price updates as well. So, using that information, again, it's not a perfect substitute for having full complete claims data, but there's a high ability to predict like what that all episode spending is likely to be, over a good number of cases based off of the initial EHR data, which again can be something like within like a week or so can be starting to get a view of expected performance in the program.
Great, thanks, Derek. So that's interesting. So being able, and I know you've done this also some in BPCI, can you give an example of a success story of being able to see the data or having that prediction much sooner than waiting for that data and how that affected their success in the bundle payment program?
Yeah, I mean, certainly like in the BPCI Advanced program, it was the need for the closer real-time view is even more acute than in the team program for two reasons. One, the BPCI Advanced program has a 90-day episode length, and so it takes even longer to have all the claims data come in for those cases. And two, the number of variables that are included in the CMS risk adjusting methodology for the target prices was even bigger than in team. They've somewhat simplified the methodology for the team program as well. And so for both those reasons, like in the BPCI Advanced program, it was incredibly important to be able to uh, have a much more timely view of performance. Another kind of complicating factor in the BPCI Advanced program is, right now, CMS is quite behind with doing its semi-annual reconciliation in that program as well. They've had some issues from like a data, processing perspective with their claims data. And so even waiting for that claims data, you're going to wait even longer than it should take based off of the CMS being slow to process that claims data in the program, which hopefully won't happen in the team model, but it's certainly a risk there as well.
Right. Thank you. No, that's interesting. And now as we think about the overall claim, let's dig into the post-acute care as we looked at the managed and the unmanaged patient. There's a big difference in that post-acute care portion. Derek, I know you've done a lot of work in that. Can you share what Avant-garde and what you've done to help hospitals make correct choices and placement in regards to post-acute care? And being able to even drill down on how that looks different from someone who's getting a knee replacement compared to someone who's getting a cabbage as part of CMS team.
Yeah, absolutely. So hopefully patients are able to be discharged home successfully, but see, there's many patients who do need to go to some level of care post-discharge, whether it's a facility like inpatient rehab or skilled nursing facility or get home health afterwards. And perhaps not surprisingly, there's tremendous variation in the relative quality and efficacy of those different post-acute care providers. And so there's an enormous opportunity, even upon, hopefully, again, patients go home, but if they need some level of care post-discharge, to select the better performing facilities for those patients to go to. And certainly the patients have free choice here. But patients don't want to go to a facility where they're going to stay an extra 10 days longer than they need to, or have a 20% higher chance of being readmitted to the hospital. And so it's possible through like data analysis to not just like use the CMS star ratings for the facilities, but to like get to like much more granular types of insights to be able to like say specifically for other patients who had that same procedure, or reason for being in the hospital, like whether it's heart failure or what, uh, for other patients like me going to these facilities, like what is like the average length of stay for them? What is like the probability being readmitted for these as well? And to be able to look at that based off of my location as a patient, if I'm close to the hospital, if I'm not close to the hospital, to find high performing facilities. And our observation is like many health systems uh, will have like a set of preferred post-acute care partners. But even amongst those partners, there's a lot of variation in the relative ability to be good at taking care of different kinds of patients. Like we might see like one skilled nursing facility as being really good at managing joint replacement patients. Another facility is like really good at managing the heart failure patients. And so even amongst your preferred network, based off of patients' diagnoses, like identifying those better performing facilities, and then being able to like present the information to patients in a way, again, where they have free choice, but like where you're using data to help them make informed choices about where to go is incredibly powerful for the case management teams.
Yeah, thank you, Derek. One thing, this is a small aside that we see often, is it's also really easy to get in a rut of just sending every patient of a particular procedure to the same spot. So we often will see, everyone is sending a total knee replacement patient home with home health care, not realizing that you could probably have a good chunk of those patients going home with outpatient physical therapy, which is obviously going to be cheaper. So having that data as well, just being able to understand where those patients are going and a little bit of foresight and being able to understand then, Derek, as you had explained, if we are going to use a sniff or an IRF, let's have this planned and well thought out before the patient comes, or at least have it on the radar. So this is very well a part of the mechanical and operational process, not just a reactive portion of getting the patient discharged. So I think this is helpful, Derek. Moving on and just looking at these different components of where we can drive success within CMS Team. You recently published an article in Harvard Business Review in regards to physician engagement. And I think physician engagement can go, beyond team, but is specifically important in a program like CMS Team because you have this outside care that's being provided, and we need to be very have a concerted effort of what we're doing with the patient, let's say leave. So would love to hear your thoughts and just your experience on driving that engagement. What tends to work? What would you suggest in regards to having that proper engagement in CMS Team?
Yeah, I mean, the couple part answer here is certainly, for these surgical episodes in particular, physicians are very important uh, influencers of the success in the bundle payment model. And uh, in terms of like getting them to be as engaged and their practices more broadly to be as engaged, there's a few different ways we think about this. The first is being able to just help them, their offices as well as the hospital have as much visibility ahead of time to which patients are going to be a part of the team or relevant bundle payment model is really important. So they can start to work with the patient uh, to their families to try and coordinate on a game plan to hopefully allow that patient to be able to go home successfully after the surgery to prepare their home, ensure there's a family member or close friend who's able to help take care of them. Uh, that's incredibly important as is like ahead of time. Again, just having the visibility to help ensure that everything from a comorbidity and um, perspective is documented for that patient. And then uh, in terms of like physicians are generally speaking want to have access to as much data as possible. Again, coming back to a child of two physicians, siblings of two physicians, my brother and sisters-in-laws are essentially all physicians. So they want to have as much information as possible. And oftentimes they feel like they don't have the key insights they need to be as successful as possible. And they also want to make sure they're doing at least as well as their colleagues. Nobody wants to be an outlier in terms of like their relative performance. And to be able to share the data with them to help them understand, like here's like what's best practice in terms of like what's attainable, like what's realistic based on their surgical specialty and their patient case mix on a risk-adjusted basis for like, what percentage of the patients should be able to go home or which facilities are better performing. Being able to empower them with that data is really, really helpful as well. And then beyond the data and having those timely insights to Porter's point about the uh, article we published as well. So just to, if I go and share my screen here quickly, Porter.
Just a moment. Yes. There we go.
So this is the article that Porter is referring to. We published this last October. This is our 12th Harvard Business Review article, and it's around the theme of physician hospital financial alignment for cost management. And as part of the team program, this article is not specific to bundles. It's just meant to be a framework more broadly for helping health systems physicians like have a way of like thinking about uh, creating alignment, but financial alignment between them to be able to deliver care as cost effectively as possible. But as it relates to like the team or bundle payment programs, there's the ability to like look at how much each physician is contributing to any earnings in the program, which are called reconciliations in the team program. And so like at the end of each performance period, you can see, like, hey, like if this hospital earned $500,000, here's how much of that $500,000 in earnings was contributed to by each different physician. And so there's the ability to like have that transparency again around like, each person's contributions. And we've certainly seen many health systems be successful with like sharing a portion of any earnings with physicians. It's again somewhat in proportion to like their relative contributions to the overall program success. Or some places like like to share the gains like equally amongst the physicians as well. So I would say like, number one is thing we talked about here is just making sure people have visibility in terms of patients are going to be in the program in enough time so that they can help optimize their care. I mean, everybody wants the patients to do as well as possible. Secondly, is just having the data to help them understand, comparatively speaking, how they're doing, like what are reasonable goals for like where they should be able to achieve from a performance perspective. And thirdly, like having a little bit of economic skin in the game can be helpful as well.
No, that's great. Appreciate it. We hear often that that is just such a big component of driving success in this is having the physician's input and buy-in, that they want to be participatory and want to see this type of program succeed. And I heard, from one physician best that they hope that everything that is learned and implemented for team also gets rolled out to the entire patient population, because from their perspective, that is going to create successful patient care within their department, within their hospital.
Yep, I agree with you.
Cindy, can I lean on you? I wasn't planning on it, but I'd love to hear your thoughts as a CEO of a large health system in regards to physicians.
Yeah,
You've lived it and breathed it.
I've been waiting for the minute to say this. So, one of the things that we spent an enormous amount of time on, both at the Cleveland Clinic and Allegheny Health Network, was making sure that we truly, truly understood the cost of care. You can't spend enough time in knowing what it costs you to perform this DRG, this CPT code. And it's something that you have to look at continuously. And it's painful and it takes a lot of time, but you'll never know whether you're making money or losing money on this kind of thing unless you know what your cost of care is. So the program is great. I completely understood everything that you guys said, but let's just say you layer that on top of something that a hospital would say, well, this is my cost of care for this particular procedure or DRG, and it's wrong, it's way off. Well, then you're going to be way off on the financials too. So it's something that you really have to pay attention to. I'm sure that you're doing it, but I can't stress how important it is.
Yeah, I think that's helpful. So let's dovetail that in. Derek, you had mentioned that the cost of care reducing the implant for CMS team isn't going to necessarily change your your overall outputs for reconciliation. So tell us how that works, Derek, when you loop in what Cindy just said, that cost of care, but then how does that affect your CMS team reality as you're treating those patients? How does this all come together?
Well, yeah, I mean, so when looking at the cost, the cost that the hospital or the practice incurs, uh, those aren't going to be factored into the CMS calculation for like if the hospital's earning or losing money in the team program. The only metric that CMS itself cares about is measuring is basically the paid claims for that episode. So if it's not impacting the paid claims, it's not going to impact the calculation of how that hospital performed in the program. That being said, from a hospital's perspective, things that even they don't impact the paid claims, but do impact their own costs, those are still incredibly important to manage. To basically, you're not getting incremental payment for having incremental costs, and so to the extent that you can do a better job of delivering that care as efficiently as possible, like that's going to help improve your overall margins as a
Right.
hospital. Like the only thing there would be like, I mean, if you have like a patient that's staying 2 nights and is going to be an inpatient, and like, now you can discharge them same day and they're an outpatient case, that might also slightly decrease like the payment to the hospital if it's, being as an outpatient versus inpatient case. But, that's going to be a big difference from a cost perspective, to do that as the same day procedure as well.
Right. Right. Correct. Thank you.
No, that is good. So if I understand that correctly, you're going to increase your margin if you can decrease your costs. And then as that reconciliation comes in, assuming you're doing well on the post-acute care, it's just going to compound that margin that you're going to have for that individual patient. Is that correct?
Yep.
Right. Okay. And Cindy, appreciate you bringing that up. I think we often are so remiss in healthcare of not looking at costs. I know when I worked for a large health system, we looked at costs on a departmental basis, which
Right.
was fine, but it didn't really allow us to do a lot in regards to improvements. So getting down, you mentioned that DRG level is so important to really drive change.
Right. And Porter, to be able to compare provider by provider for the same procedure, is absolutely, I mean, it's so important. And we made so much headway in both organizations when we did that. And I think it was a surprise to the clinicians, but data is data, and they will embrace data if it's accurate and try to determine how they can make it better. So I'm just saying, and at any point with any of these programs, you have to make sure that they understand what it's costing them to perform this procedure compared to their colleagues.
Yeah. No, I think that's right, exactly right. Um, all right, so I wanna now take this next step and how do you, and this is a question for both of you, and Cindy, let's start with you. How do you see the team program being able to affect the care for all patients, and really driving that value-based care equation? Or is that a pipe dream? What
No,
what
it's not a
what are
pipe
we
dream.
looking at?
Well, we all know that value-based care is coming, whether we like it or not. And we have to find a way how to do it and do it better. People need to embrace it. We've got a lot of people working on that right now. I know at the CEO Advisory Network, we've got a number of people that we spend a lot of time with systems talking to them about how to do it really, really effectively. But there is no doubt that value-based care is coming, and it's coming like a train down the tracks right now. And you can't do it at the last minute. You have to plan for this 2 or 3 years in advance so that you can inform your providers and teach them how to think about this. So what I think is going to happen, I think this Teams program will be very effective because it's a group of 700 and something hospitals that are going to be the first group that goes through it, and then they'll expand it after that to more hospitals, more procedures. So people need to figure out how to do it now and learn by this first year, and pay attention to what went well and what didn't go well, so that they can figure out how they're going to do it themselves, because they're going to be doing it.
Yeah,
No
yeah.
doubt.
They're going to be doing it, and this time it's mandatory, right? This is
That's
different
right.
than some of
That's
the other
right.
programs,
That's
so it's
right.
mandatory.
Right.
Derek, what are your thoughts? How do you think it's going to roll out? Can it bring us closer to value-based care?
Yeah, I mean, I would say I think there's a high probability of there being expansion of the scope here from the initial 5 surgical bundles to additional surgical bundles and then to medical bundles over time as well. I mean, there are about 3 dozen or so different clinical areas in I think like the BP side advanced program. And I think the issue CMS faced in the BPC Advanced program was like it was a voluntary program, and so basically many people who participated in it, like were ones that were set up to do well in it. But with it being team now a mandatory model, it's a way of CMS kind of essentially guaranteeing that they're going to come out ahead, and they're under so much pressure to lower healthcare costs, just given the budget pressures, the federal government. It's a basically guaranteed way for them to save money, and so I certainly anticipate over the next several years that the model will grow.
Yeah,
Yeah,
I agree. I think it will too.
that's interesting. Two more questions. Final one. Curious if you see AI playing a role in CMS team. Just this advancement of technology, and would love to give your thoughts and take on that.
Mhm. You go
Yeah,
first.
I mean, I would say I think like in anything from an analytics perspective, AI is going to give people like a huge leg up. There's definitely a uh, like night and day in my mind, like uh, comparison in terms of like how quickly you can get to key insights through AI versus like trying to comb through the data yourself manually. And it also just makes it so much more accessible for people who aren't analytics gurus themselves, just to be able to uh, use generative AI to like type in a question and get their answers back in seconds. And so it really helps democratize access to key insights as well.
Yeah, I completely agree, Porter. I don't have a lot to add. All of us have been looking at the systems that have rolled out, the different AI products that are available right now that are helping the clinicians save time, but are very, very accurate at this point. And I think that we're going to continue to see more and more and more of those. And they'll just get better and better. And at some point, it'll just be, AI everywhere. But we have to do it in a way that we make sure that it's accurate, the patients aren't being harmed, that, all that kind of, that's what I worry about sometimes, is that there are so many products being thrown at providers that they don't know which way to turn. But I do think that some of the bigger providers that are going into these areas right now will start to produce data on the accuracy of AI within their provider system, and it will help guide others in this area. So we'll see.
Yeah, no, I 100% agree. Just finally to close out, what would be your 30-second piece of advice to those that are just starting or thinking about bundled payments? There's so many facets to it. I'm sure there's, a lot that you could provide, but Cindy, we'll start with you and finish off with Derek.
Well,
What would you say of how to be successful and what should you be thinking about?
I,
Um,
Yeah, I think, Porter, that if you're one of the 700 and something hospitals that are going live on January 1st, you got to go fast at this point. You have to understand exactly what it is that you need to do, and you need to work with organizations like Avant-garde, who knows how to do it very well. They hold, I think it's monthly, correct, webinars with hundreds of people that have guided them through this. So you can't at this point, I think, start from scratch because you don't have enough time. But you got to pay attention to it because it's not only starting with this group of procedures, but it'll go right into another group after that. So learn from others. That's my message.
It's a great message. And just to follow up on that, and then I'll give it to you, Derek. Cindy's referring to our collaborative.
Right.
This is the Avant-garde Health CMS Team Collaborative. We have over 100 hospitals, about 250 to 300 registered participants. We come in, we learn. Last month, we learned from Penn State Hershey and University of Arkansas and their successes and how they're preparing for team. We've got Advocate teed up to share their experiences. So it's been a wonderful learning experience. And we know that people are connecting hospital to hospital because of this. And everyone's at a different phase. Some people have got a decades of experience under their belt, like Derek, with these bundled payments, and some are just starting now. So appreciate you bringing that up. And Derek will give you the final word.
Yeah, and I think like just learning what hasn't worked for people as well is really valuable in addition to things that have worked. And everybody that's been in the bundle space for a while has had simple successes and some failures along the way. I mean, I think just adding to what Cindy was sharing and kind of recapping the conversation from today, I certainly think that just having as robust a set of uh, insights and view into uh, how your performance is tracking in a timely fashion and what to do to continue to improve and get better is paramount to success. And so like that the faster you can, fail quickly here, the faster you can learn, see what's working, the faster you can understand where the opportunities are, the more likely you are to be successful in the program.
That's great.
We do
Derek,
have a question if you'd like.
yes, let's take it. Thank you for letting us know.
Yeah. How does the hospital become part of the Teams collaborative? Does it cost anything to join?
Great question. And no, it does not cost anything to join. We are the price of admission is your willingness to be collaborative with the other members. So everyone does like to speak and engage, inside and outside of the webinars in the formal meetings. So we would love to have you join, and we'd be happy to have you participate. We've got a whole treasure trove of assets that we provide as you become part of the collaborative, along with those monthly webinars.
Yeah, we did, I think, about 150 or so people on the webinar last week, and happy to include anybody else that's interested in the series going forward.
Yeah.
So thank you to Cindy and the CEO Advisory Network for hosting us today. Really enjoyed the conversation and opportunity to talk about the team program with everybody.
Yeah, thank you. It was great information, and I can only imagine that we're going to keep having these conversations, as time goes forward, because they're going to for sure roll out more procedures without a doubt. If you go to the next slide real quick, I just wanted to mention that we'll be holding a healthcare roundtable October 15th to 17th at the Oxford Hotel in Denver, Colorado. We meet twice a year, and the topic of this meeting will be: Will you be a disruptor or will you be disrupted? And you can see the speaker there, and he is like really, really well known, and it's going to be really exciting to hear him. So if you would like to participate, please contact Marty Hauser. You can see his information on this slide right here. But we would love to have you join us. And both of you, thank you so much for taking the time to do this. And Kristen, thank you for taking the time to set this all up. It was very, very informative. Really appreciate it.
Well, thank you, Cindy. Appreciate it.
You're welcome.
Thank you, everyone, and have a great afternoon. Thank you to all our speakers.
Thank you.
Thank you.